Okay, so just to let everyone know that we're currently recording. So I'm going to turn. All right. About all of the conversations you've already had with WHO, because it sounds like they've been quite constructive with WHO and the Ministry of Health in Nepal, which is fantastic. And at the global and some other regional levels as well. And then also to go into
Rachel, your voice is breaking, I guess.
Is it? Okay. Yeah. Thank you for letting me know. Maybe please wait one moment. I'm just going to try to reset something. I apologize. We've had some issues recently. But perhaps while I start, because the audio for me is fine. I think it's my voice. Would it be possible to maybe do a quick introduction about some of the discussions that have been ongoing with WHO and Ministry of Health, and maybe what this, if any, strategic goals or alignments or concerns that maybe have come up in those discussions? And let me reset something with my internet during the process. I'm not sure if who might be the best to take that.
Maybe Surakshaji, if you can explain, yeah.
Yes, sure, sir. Rachel, for what you just addressed on, we had a round of discussion with WHO on basic of how the community-based surveillance might be functioning in context of Nepal. Specifically, the discussion was over the geographical locations, and so we did discuss regarding the assessment tool, which is the initial process of implementing CBS, and we just had a brief maybe a brainstorming on how can it be done, or where can we do it, some sort of like that. There is no any concretely discussed roles or such until now. For the sake of on the part of ministry, we are yet to discuss, because we are first thinking to do it internally, then go for ministry level conversation, and so that's the small up to now progress. Yeah, Rujina ji can add up to this.
Thank you, Surakshaji. I would like to give a very short background about community-based surveillance in Nepal. So far, if we talk about the CBS in Nepal, there is one concerned body, epidemiology body, a center, and they do some sort of surveillance, but that is based on the health facility. The lowermost level of grassroots level of health facility that they do capture the data from our local health post. So there is no any such community-based surveillance for the other types of information from the community itself. Having said that, there is a system of family health family community health volunteer, sorry, not family, female community health volunteers. They also provide some to some extent of surveillance from the community to the local health post, and the health post they directly provide the information to the district hospital, and from the district hospitals those informations goes to the center epidemiology department, and they also have one early warning and detection system. So apart from that, there is a missing link for the community-based surveillance. And we, as Suraksha ji has already told, we had started a dialogue with WHO to work on this part. And for the assessment, we have some more queries in order to start in the scenario of COVID-19. So maybe we will provide those queries later on. Thank you. Over.
Okay, that's quite helpful. Can you hear me now a little better?
Yeah, it's fine.
Okay, thank you, and I'm sorry for that. Okay, so it sounds like then the majority of the conversations at this time have been with WHO, but then to link in Ministry of Health once a more concrete strategy is developed. And also in terms of the existing systems for surveillance, I think also it sounds like it will fit quite well. It might be useful then to go through a few of the pieces on the assessment tool. I know you've already looked through it as well, so I can go quickly to kind of give, I have a presentation I shared. And so I don't need to spend all the time. I think maybe it will be the most useful to have a bit of a discussion on questions that have come up. But maybe I will start first with a short discussion on my side, what I've been coordinating with WHO at the global level. And we've been in a lot of discussions recently on how community-based surveillance can be used as kind of that last link, as you mentioned, I think also in Nepal, where it's that missing link at the community level, where some of that surveillance information is not reaching either at the district hospital or even down at the local health posts. Most of our community-based surveillance projects are linked directly to the local health post, in which case then the information can be shared up through the existing systems that you have here. So through this strategy, WHO is seeing CBS also for COVID, along with other epidemic-prone diseases, can be used and should be used in scenarios where it's feasible to help promote surveillance in these areas. So they've been quite positive globally on that, and it's very good to hear the discussions in Nepal with the WHO office there have been similar, it sounds. We also have been discussing recently the need to continue to always review the community case definition for COVID-19 and how to include it in the surveillance strategy. So I will get to this in a moment, but that will come up kind of during these discussions. I've been engaged with those working on the updated suspect case definition for COVID-19. And we've been discussing whether or not to include a community case definition for COVID-19 in new surveillance guidance that will be updated from WHO. At this time, they're very much interested in our national societies who have found what we've used so far useful. Given the feedback, we have a meeting this afternoon. Given the feedback from some other national societies, I think we will probably try to keep our community case definition very sensitive. But this is also something that can be discussed at the national society level so that you're always in alignment with your with WHO, but also your Ministry of Health. And I kind of mentioned that each Ministry of Health does occasionally have a slightly different case definition. So when it comes to COVID-19, to just keep that in mind, and it's okay. And I'm also happy to provide support on that as well. maybe I'm just going to skip through a few things. I always include a table. You're already past the discussions on some of the different options for surveillance strategies. But just to kind of as a reminder that some of these are useful in communities where maybe CBS is not the most feasible option. There are a couple other reporting mechanisms similar to what some of the female community volunteers are engaged in now that we can also integrate into some of your projects if it's useful. So for the community case definition, our strategy and approach, and WHO is aware that we work more on a syndromic, so kind of a health risk, rather than putting the burden of identifying cases on our volunteers. They're more just interested in whether or not they see something that should be alerted as a health risk in the community. And this then allows us to go through and follow kind of a similar procedure where it goes up to the local health post or those who are responsible for following up on suspected cases. So this will be, it's very good to be in discussion with WHO, and then this should also include Ministry of Health when determining the process for that. I just pulled up on the screen now what we do have in our guidance at the moment for the health risk suggested for COVID-19. And I might pause here to ask if you are also looking at potentially including CBS for other diseases as well, or is the primary focus at this time COVID-19?
Maybe Ramesh sir is here from CRC. He might be also highlighting some.
Okay.
He has good experience in health system work related like HMIS and other things. So I can share based on my discussion with WHO with Dr. Ruben. Actually, and also we think we can start at this point during the COVID, but this tool if like sustained and properly used would be very beneficial for post-COVID setting also. Like there are different seasonal diseases that occurs in Nepal and which are not like rightly reported, and there are negligible regional types of diseases. So maybe sometimes it is difficult to get the report in government system where it appears sometimes when the numbers are great or in large numbers, then only our system knows about it. It's reported to the system. So maybe we have discussed. Maybe we start at this point. Maybe piloting some in few areas. Also, it can be utilized in post COVID situation. Ramesh sir, if you want to add some.
Yes, definitely, Bipul sir, and thank you for this opportunity as well. Actually, it was also discussed during our meeting with WHO, and what we concluded in our discussion was basically not only from pandemic, Nepal has been also affected or affecting from several epidemic outbreak as well. And since we are just approaching or entering into the monsoon season, we can foresee the epidemic or sporadic outbreak of cholera and diarrhea as well. Besides these, dengue are the most emerging disease in Nepali context. So what we discussed with WHO in our meeting was, let's focus on COVID-19, of course, but at the meantime, we should also focus on the other diseases like other epidemic diseases like dengue and cholera as well. That was also discussed, and I think that is the demand or the need of the situation as well.
It's a really good background. Thank you. I think I see a hand up. Sorry, I might pronounce your name wrong. Is it Sariksha?
Yeah, Rachel, regarding this context, I also had noted out question on the same line. Like, while customizing the software for all these, should we have a disease or same disease throughout, or can we have some disease specific to geographical areas? This is because like some disease problematic to the plain terrains and Tarai might not be a problem for the Himalaya regions. So can it be customized in that way also? Just my query on that. Yeah.
I'm really glad you brought that up, actually. And I thank you for pointing it out, because we are looking at revising how we do our demonstrations too. So very good question. The answer is yes. And your point on the diseases that are kind of high priority in the Himalaya region are not going to be the same as in the plains. So it is extremely context driven. So if, for example, you're using the Nyss platform, yes, so you can use different focus basically on different diseases for different areas. Now, the way that the platform, we suggest using the platform, and this is also true, even in a more traditional, if you were to use Kobo or something along these lines, is we always suggest having kind of a national strategy and approach. But of course, in different areas, you might have slightly different focuses based off of the priorities. So for example, if you have in one area, your high priority is diarrheal diseases, you may have, do your trainings, you would focus on, for example, those health risks affiliated with those diseases that you're most interested in those areas. As well as we usually do always suggest including something like cluster of unusual illnesses or deaths, because it helps capture that unknown or that off variable. But you would train then your volunteers and colleagues in those areas on those specific diseases. Whereas if in another region, respiratory diseases were the main concern, you would train on those health risks. And so the reporting would be specific for those areas. But the system, what we would recommend then is to set up the system with all the diseases, all of the health risks that you'll be using, but you would only see the relevant ones for the region. So it's a really good point to bring up. And I think I'll see if I can create maybe something that can visualize this for you a little bit better, but it's a good question. So I do highly suggest, and this actually will be part of the assessment process, is just that, is noting what areas and what health risks are high priority at a national level, but also at a sub-national level, and what to focus on. And also, I think it's a very good point made. So what we've been talking about in many national societies is, yes, we have kind of an emergency now with COVID-19, but it's also a good opportunity. We can use this to initiate some projects. And as we move on, what we've done in other emergencies in the past is then slowly integrate additional health risks that might be relevant for the region. And so this has worked quite well in Uganda, for example, where they had to start very quickly with Ebola, but then they slowly integrated a few of the other high priority health risks. And they just had to build off of all of the already trained volunteers. And it's been quite a useful strategy. I do recommend keeping your health risks to a minimum. I generally don't suggest more than 5, but of course it does vary context to context. And even within countries, it might vary location to location. So maybe just a note. Let me move on here then. So this is part of what was mentioned also about building off of kind of some of the existing structures. So I know there's some community health projects ongoing and some volunteers trained in health and first aid in Nepal. And so one of the strategies we've used for CBS is building off of the strengths that are already existing within the National Society. So if we have strong community health volunteers, adding an additional small training on how to do community-based surveillance facilitates kind of a nice approach to being able to keep the sustainability of this as we move forward as well. So I'm just going to skip through a few pieces here because I don't want to spend too much time on this. But it is extremely important then that it's also linked to those community actions. So with community-based surveillance, it's not using volunteers to provide surveillance at a community level, but it's also providing that link for the community to the support that they might need. So whether this be referrals to the local health post or district hospital, or whether it be kind of your basic community-based health and first aid or epidemic control or risk communication. It's really important to have these links identified as part of your assessment process. And this also it's nice to do this actually with a partner. So if WHO is looking to partner on this, or others are looking to partner, it's great to hear also from the broader perspective who might be a good partner. Sorry, I'm just going to skip through here quickly. Okay, and just to come back to the reporting structure. So as mentioned on this, so after kind of the training piece, the ways in which reporting structure works is having the volunteer either through SMS, which is probably the most common form, but there are other forms if this is not appropriate, but sending an SMS to the Red Crescent supervisor. So we use the supervisor position, and it's important to kind of note this for WHO as well. We use the supervisor position to cross-check those community reports that they're sending. And this is so that we don't overburden the health system or the the early warning and alerting system. And we found that this is quite useful in trying to help identify, yes, it meets our community case definition for the health risk, or if not, we can provide feedback to the volunteer and provide the appropriate support or follow-up needed. But the report doesn't need to be escalated then to those who will follow up on the disease and the tracking. So following, if the report then is cross-checked and found that it does, yes, indeed, it does meet the decided community case definition, then you escalate to the health authorities. So this is a big piece of the assessment process, is identifying just who those health authorities would be. It is a little bit different, and it might vary subnationally as well in Nepal. And so this is why it's important to link then to Ministry of Health, both at the national level, but also at the local or the district level. And here we usually, there's a team who does case investigations. Especially with COVID, they might be receiving support from WHO or other partners. So part of the assessment here will be identifying those key partners in that immediate case investigation and follow-up piece. And this is extremely important also to kind of re-emphasize this approach at the volunteer level as well. And it's important to always have this follow-up at the local level so that there's some action that's taken. And this also encourages volunteers in the community to continue to go through the process with community-based surveillance. So this key piece, I just bring that up because especially during a pandemic, it might not always be your traditional, it might not be the same person always. So you might always have case investigation through your district health hospital, for example. But during the pandemic, there might be other actors on the ground who would be supporting in this. And so this will be a good opportunity to identify whether it's WHO, whether it's Ministry of Health or another partner at the local kind of health post level for that first piece of the follow-up. Once you go through this process, it will actually follow, it sounds like there's a pretty strong health system for surveillance for the health facility level. And so once it goes through this, the community-based surveillance piece is in some ways done. Well, it'll go through the investigation, and then through your traditional, if they're doing the testing, etc., this will go through the same process for surveillance. So a key piece of this is linking in through the existing surveillance structures. And so whether that's through the national surveillance system or additionally any other systems that are put in place. I want to pause here because I think that's a key point, is to bring up this piece that, and I liked the way that you already phrased it as seeing it as the missing link to the already existing surveillance structure. But one of the biggest pieces of this assessment is figuring out at the local level who the appropriate link is for that. I just want to pause in case there's any questions on that approach. And while I'm paused, I'm just going to skip ahead. Yes, Ramesh. I think I see a hand. Go ahead.
Okay, yes, thank you for a brief information, or I must say it's a comprehensive information about the CBS. And my question is about the interrelation between the community-based surveillance and the health facility-based disease surveillance. So based on your experience, or are there any good practices from any countries about the good coherence between the community-based surveillance and the health facility-based disease surveillance, especially in case of a rapid detection of any diseases outbreak?
Yes, no, it's a very good question. So yes, we've had some great experiences. And we are trying to work on sharing more. In my follow-up email to all of you, I can share some of the links to stories that have been published before. This link is extremely important to that follow-up. So it's been useful in detecting kind of outbreaks of cholera, for example, in Somaliland. I know Somaliland's gotten a lot of publicity recently because they've also used this to detect COVID-19. But also ahead of this time, it's been used to also detect multiple other outbreaks, including a Salmonella outbreak, actually, in which the health post was able to quickly follow up and locate back to kind of where the outbreak started and be able to stop that. And that was one of our greatest examples, I think. But also it's been used for cholera and identifying cholera hotspots, especially going into, as you mentioned, sometimes a rainy season, and as a seasonal approach to trying to identify and locate areas to set up ORPs for community support. In Kenya, it's been used quite successfully. We also in our system have animal health risks affiliated with animal diseases as well. And so in those, we've been able to identify Rift Valley fever, and it has led to some large-scale vaccination campaigns there, which have been extremely successful as well. And so that's a bit of a different system because it wasn't necessarily only through the the human, the health facility, and the disease surveillance system, but that actually also went into their animal surveillance system and their veterinary follow-up. So depending on the context, it is important to make those links to both. Coming back to the point on the disease indicator surveillance structures and those systems within the health post, the ways in which we report on community-based surveillance, we do try to emphasize still that we're reporting on health risks. And in WHO, kind of the EBS language, they kind of refer to them as signals. Because we do not want to put the burden of identifying specific diseases on our volunteers. It does sound like you have many health trained volunteers, but we also don't want to limit our volunteers to only health professionals. And so our approach is really to identify at a syndromic level. So to identify those symptoms and then push that through into the existing health surveillance system. And so once it is identified or confirmed, that's when it would actually then go directly into the traditional disease indicator surveillance system. Whereas the community, the alert that's coming from the community-based surveillance piece is a health risk. So it's the symptoms that are related to that. I don't know if I answered the question. But I can also share a few examples that might be useful for you when you're just discussing with WHO and partners as well. Just going to make a note.
Yes, thank you. This is a helpful information. And if you have any further document, it will be much helpful for us.
Yeah, so I'm going to share, I'm just making notes also on additional resources that'll be useful to share for your discussion. So I can share some links to some kind of successful examples in the past, but also we have kind of an advocacy toolkit that we are working on. Before COVID, we were going to update our guiding principles and put those into that. Because of COVID, it got delayed, but I'm happy to share the drafts because they may be useful for some of your discussion. So I'll just send them along as well. All right. So maybe also just to go in, because I want to go through the pieces of our community-based surveillance assessment tool and why we developed it. So this tool has been developed not necessarily with a rapid assessment in mind. However, it can be used for a rapid assessment still. So it's been developed basically to facilitate initial assessment by national societies and partners to figure out what existing surveillance systems already are in place. So for example, this is already identified by your team, and to identify also the strengths and capacities and then the gaps that might be needed to fill. So the tool has been developed to just walk through this whole process in order to organize it in a way to come up with the next steps and develop the protocol. So it starts with defining kind of the key objectives within, and we say the National Society a lot, but also keeping in mind, it's great to do this assessment process with partners engaged. So if it's WHO country office, that's perfect as well. Defining the data sources, and so this is just kind of an understanding of whether it's MOH, the national surveillance system, whether it's WHO, et cetera. And then also identifying who needs to be spoken with to finalize the assessment. Usually it will need to include some discussions or interviews, both at national and subnational and local levels. And then finally, I would suggest, and I think, I forget who mentioned this earlier in the call, but I would suggest trying to do this in an approach where you maybe already have some links on kind of, I'm sorry, I'm going to skip real quick to a chart that I have. Some links where you have presence with volunteers within the community, where there might be gaps and a need for this community-based surveillance. And then we already know about the one epidemic outbreak, but also keeping in mind that where you may also want to scale up community-based surveillance in the future. And so that would be my suggestion in terms of finding out and selecting locations to begin. And it might be most simple to start in specific areas and scale up as needed or when useful. Especially if you're working with partners on the ground. Now that we have Nyss operates and allows for multiple organizations, it also is a great opportunity to partner with others in other areas to extend the coverage of community-based surveillance without putting too much pressure on the volunteers. I'll skip back up here. So, I mean, the key objectives really is one, determining the need for CBS. This is part of the process of the assessment. I also like to emphasize that it sounds like a lot of these steps have already informally or formally been started, or the discussions at least. So it's looking at whether or not CBS would be an appropriate strategy to fill these gaps, and what additional information you might need to answer that question. Additionally, we're looking at if the National Society and the structure and what community-based volunteers are already doing, and if we're the best partner in each location. So this goes back to kind of determining what work is already ongoing, the capacity of volunteers to take on a few new roles or a little bit of additional training, as well as maybe identifying locations or specific localities where CBS may be quite practical for the National Society in one area, but maybe where there might be gaps for others to fill in as well. If it's feasible, again, this is a little bit different given COVID. So there are multiple strategies, and one option is to kind of scale up community-based surveillance, thinking of COVID-19, and then to maybe adjust your locations based on other epidemic-prone diseases that you're interested in later. But thinking about kind of the sustainability and longevity as well, because I do think it's a good opportunity to kind of scale this in locations where it'll be most useful and practical moving forward as well. And then also to assess kind of the potential modality and structure. So this is a bit of the, I call it the techie pieces. One option was kind of discussed by Nikolai yesterday in the demo of Nyss platform. But this is also looking at kind of the recommended geographical areas, and just listing out these specifics. It also includes coming up with those localized recommended diseases and therefore health risks to focus on. And what I've done in the past, and I found useful, is kind of come up with my ideal list and then go down and kind of prioritize. And so that might be one option as well. And it will allow you to then scale up later on by using this assessment that's already done. It's also important to look at the data structure and what's available within the community, whether people have phones to report, whether there is someone available to help analyze the data, and how that data will be kind of linking in to the other structures. So these are kind of the key goals of the assessment process. And I do know you've discussed a little bit now, at least with WHO, on the gaps identified, but maybe it will help provide a little bit of better guidance on perhaps starting with specific locations or doing a national assessment, and kind of keeping that in mind, though, at that sub-national level. We do typically use kind of your standard data. So when it comes to identifying health risks at both the national or subnational level, we do recommend using either the JEE or DHS or other Ministry of Health national data reports to help identify either prioritized areas or health risks you might want to focus on. And then making sure that also these discussions take place with the other partners, just to kind of keep everyone engaged, because the goal really is to have one approach to community-based surveillance within the country. And whether or not other partners are involved, it's still great to have the one approach, even if there's other partners. And I won't spend time on these tools because I'm just showing they're here. The tools, these are not mandatory tools by any means. We developed these based off of experience in the past, as mentioned, in doing assessments, and what we found most useful for kind of deciding whether or not to go ahead with community-based surveillance. But in the end, the key goals are to understand whether or not CBS is recommended, not recommended, or only recommended given certain parameters. And then also provide recommendation on kind of the key systems and features to use. So whether or not that would include a SMS system in Nyss, or it would include an SMS system in other forms, etc. So kind of trying to come down to a few suggestions for how to move forward, locations on where to start, and then potentially where to scale later. And then also whether or not any additional assessments are needed. If, for example, I know sometimes assessments are done and we cannot control nature, and there's a giant storm, and it's not possible to get to a location. So instead of holding up the assessment, maybe to just note that an assessment needs to be done in a specific location before scaling there as well. And we do suggest keeping, and this seems silly, but please keep your notes of interviews or any kind of useful annexes. This has been extremely useful when we're coming back to national societies at later dates, and looking at implementing community-based surveillance potentially for other health risks. And it's been really helpful to have kind of older discussions or interviews or data that were part of initial assessments, because it gives a really good starting point for the future. And I think this will also be important for Nepal following kind of your first initial assessment when thinking about COVID-19, but then also thinking about scaling up for some other high priority diseases as well. I am going to just kind of pause here. There are, I know you've seen, there's a giant list of interview questions and tools. I don't know that you need all of those tools, but just to kind of say that they are all available within the assessment document. And I also do have a Word template of the document as well. I'll share with you as you're in the process of this. But we really do suggest kind of starting with the community-based surveillance assessment at the national level, but of course also doing it at the local level to identify where to focus, which partners to engage with, and really come up with that strategic approach, all the way from kind of that local health post link to district hospital, to through the epi surveillance system, etc. Then the next step is to kind of go in and develop the national protocol. Already during this step, this is when you can begin kind of your trainings and engagement with other partners as well, because this is kind of a cooperative project. And I also feel that the protocol should kind of be a living document. So developing a protocol for your initial community-based surveillance strategy is extremely important, but also not to get too held up on it, because it's as situations change, potentially as health risks change, it's important to just keep it as a working document with partners as well. And that's fine. We can go into maybe questions. I'm sorry I just spoke for a little longer than I meant, but just wanted to touch on some of the key pieces of the assessment to move forward, and maybe open it up for questions or areas where you think maybe additional support might be needed. Or comments, perhaps, as well. I don't know. Has anyone come up with any kind of hesitations or concerns regarding conducting the assessment on any of the aspects, either how long it will take, who to talk to, what it should include, why it's important?
Yeah, Rachel, regarding the assessment process itself,
right?
There's a query like if we do the assessment collaborating with other partners, how does it go? Like, is there any past practice of how the role is defined when we go assessment process itself in the collaborative way?
Yeah, it's a very good question. And to be honest, I would say the majority of national societies have led the assessment process. So conducting the assessment itself, however, kind of engaged in different pieces, different partners. And so in terms of splitting the work, if you were to do an assessment kind of with a partner, it would probably make the most sense to ensure, I would still want to ensure though that the National Society does have these relationships built with, if interviews are being done at the district level with Ministry of Health or surveillance colleagues with the government, I do think it's important to be engaged in that. Now, if in kind of the time pressure that we have, if WHO, for example, is partnering and helping kind of do this assessment process, if they already have meetings planned at the national level and already are kind of strategizing on some other topics, it might make sense for them to then do also the assessment at that level, or those interviews that would be with the same people, and to link them together. So I don't know if I have a really good example from how other national societies have approached that, because it's very much nuanced on how kind of each piece might be, how the burden might be shared among the partners in each piece. But I would suggest doing it as best as possible in a natural way, where if some discussions are already ongoing, continue those discussions, but then also include some of the key questions or pieces that you might need to finalize an assessment. Not sure if that was helpful. I'm sorry.
Yeah, that's more clear. Thank you.
Okay.
So
yeah.
actually, I have Rachel, actually, I have a few questions related to in Nepal, we have like a female community health volunteers. I'm not sure, you might be aware about this. And at the community level, we have Red Cross volunteers. This FCSV, we say, like female community health volunteers. They are trained on different health aspects, including family planning, reproductive health, and child care, some like this, and also some communicable diseases too.
Okay.
And but they are like there is a different, like some of them are like maybe like maybe it can be like a challenge to handle technology from those people who are like a senior persons. They have started maybe in younger periods. Now there is no like a retirement or something. They are volunteers, so they are interested to volunteer, and they are working for a long time, and they might not be uh, like a technology friendly or something like that. And in other hand, we have Red Cross volunteers. They are volunteers for some period. Maybe they drop out and travel out, youth volunteers and others. So in this context, what do you think would be most feasible, aligning with those health system, with FCHVs, or maybe with Red Cross volunteers? In both, there are challenges and maybe benefit. Do you have any such experiences globally, and how other countries are managing in this context?
But can I ask maybe just a quick follow-up question? Are the female community health volunteers, are they also, they're also Nepal Red Cross volunteers, or are they separate with the more with the government or Ministry of Health?
No, they. Thank you. They are government system. They are from maybe the health post at local level. They recruit them, and some of them are obviously Red Cross volunteers as a community member. Yeah.
Right. That makes sense. And then maybe
And
just
maybe
one
one thing,
other.
just
Okay, go
they
ahead.
are not paid. Sorry, they are not paid from government, but maybe sometimes they receive some incentives, like a periodically, or maybe some motivational incentives during the training. They receive some allowances like this. Uh, they are not regularly paid. They are volunteer in our definitions too.
Okay, that's also good to know. And then for our volunteers then, so as you mentioned, it's a really good point that you mentioned that the volunteers span the spectrum of the community, where you have kind of youth volunteers all the way into a lot of those who have retired and want to volunteer. So just a quick question, are there community health, it sounds to me, I think I'm casually understand there's some community health volunteers already also as part of this, with some of the National Society volunteers as well, or who have already been trained on either first aid or other things. Is that correct? Or WASH, sorry. Okay, perfect. So the strategy that a lot of national societies have used in the past is first strengthening kind of the volunteer base that they have actually. So as you mentioned, the goal is actually, it's great to engage both kind of the youth volunteers as well as those either in the retirement age or other parts of the population, because the people that they engage with within the community are going to be a little bit different usually. And so it's really nice to have diversity in the volunteers who are engaged in community-based surveillance, because it helps with the risk communication, and it also helps identify people in different pockets of the community better. What some national societies have done in the past is also trying to build up on top of the skills that already have been trained or built within those volunteers. So for example, if we have a group of volunteers in an area where community-based surveillance is identified as maybe a need or a gap, we have volunteers who might have been trained on community-based first aid. It's a really good opportunity to then integrate some fresh training on epidemic control for volunteers, as well as community-based surveillance, and build that on top of the experiences they already have. And that's the same also, for example, if we have a group of volunteers who have been trained. Maybe we have some national societies where a lot of the youth volunteers are trained in risk communication pieces. And so building off of some of those trainings that have already taken place, or at least that engagement that's already there, to then integrate some of the epidemic control for volunteers training pieces along with community-based surveillance. I do think it's very important to always link these pieces and the structures that already exist, and however they may exist, then kind of to adjust this additional training on top of it. In the case of new volunteers, because I also know many national societies are having kind of these new volunteers, especially with COVID-19 and other emergencies ongoing in country, potentially. So in those situations, there are some training packages that we're suggesting in terms of if they're starting from a baseline of 0 and there's no kind of induction with the national society, we are suggesting to ensure that you do the traditional national society induction training, and then also pair it with some training in community-based health and first aid and epidemic control for volunteers, along with the CBS training. It sounds like a lot, but it allows you can pull the relevant pieces from each of these packages and pair that in the trainings. And I do think, again, I don't think there's a need to say we should focus on our youth volunteers, or we should focus on maybe the group that's the retired age volunteers, but rather try to engage within kind of looking at that larger community piece. It really would be ideal to actually have both of these groups engaged, but it does depend a little bit on the feasibility, and that's what's important maybe when going through the assessment process, especially in the locations of interest, is maybe to take a look at the profiles of these different groups of volunteers that exist, and to see what might make the most sense at that community level. But there's definitely, I think, a benefit to having a diversity within the volunteers. And just to maybe a quick note about technology, because I think it was a good point. Most of our projects, again, we're using more of a simple phone, so not even a smartphone, and an SMS code-based system. And so typically what our volunteers do is they have like a little postcard, if you will, and with a reminder of the number for the health risk, and we track under 5 or over 5, and sex. And those are the only 3 things they really need. And we have found that with a little bit of training, and we do practice scenarios in these trainings, that being able to text a number using just a traditional phone has worked pretty well for even those who don't feel super comfortable with technology and new adaptations, because at the volunteer level, they don't need to log into Nyss, for example. They're just doing kind of their daily activities, whether it's risk communication, whether it's other pieces, and then it's just kind of the one text system. There are other locations where that wasn't appropriate, and we do have paper-based CBS systems in some locations as well. Just kind of a note, one of the key challenges with those is that often it takes a little bit longer to share the alert up with the paper-based system. And that's why we often suggest looking into the SMS approach. But of course, there are many options available for implementing CBS. And then just a quick final note on the mention of the kind of the governments of the female community health volunteers. So it is great to engage them as well. I do think so, because they are already engaged on key pieces, family planning you mentioned, and communicable diseases. And so what, I'll just use an example from Uganda, for example. They've done is they've engaged they have kind of a similar structure with health volunteers, and several of the health volunteers with Ministry of Health also volunteer with the National Uganda Red Cross. And so they also attended the training. So we keep it open to others as well. And this might also, I don't know, again, on kind of other partners on the ground, but potentially might be useful to keep that in mind as well. And then and then the additional questions. Yeah, I don't know if that's helpful, but in a nutshell, the answer is yes. But I think trying to look at where the strengths and the capacity are very important for sustainability as well. This might be your question, actually. For countries where a national society are implementing CBS as a sustained approach, is it nationwide or particular area specific? Really good question. So we are trying to encourage having a national approach to community-based surveillance. However, usually it's implemented slightly differently based on the location. So we already discussed this in terms of the health risks that might be used, might vary a little bit from one location to the other. But overall, the general approach to community-based surveillance, so how the volunteer reports, how the supervisor does a cross-check, and how they link to the local health post or for the case identification and follow-up through the national surveillance systems, etc. How that's all linked should always be consistent, I would say, at a national level. But then how it's implemented in terms of your health risks and in terms of where you're actually implementing CVS should always be done a little bit more locally. So I don't think it's feasible for most countries to do community-based surveillance throughout the entire country. If there's lots of partners and it is feasible, that's exciting and fantastic. But I would say most countries do have specific kind of districts that they focus community-based surveillance in. In Uganda, for example, it's, I think, 12 of their districts are implementing community-based surveillance, and not all of them are using the same health risks. And the same in Kenya. It's by no means all of the national societies all of the country implementing community-based surveillance, but specific locations where it's deemed important. So I really don't suggest doing it at the national level, but I do think it's good to have a national level approach. Are there any other questions or something that was unclear that I said maybe? Okay, great.
Rachel?
Yes.
My query is basically about, it's focused on the technical and resource-based things, because when we think about implementing the Nyss system, there obviously comes the thing that is related to the financial resources that is required. And when, based on our internal discussion, it was we have anticipated that there might be some problem based on, because even the idea about the data storage that was raised in yesterday's meeting. So that might be one of the problems that might be faced in the future if we go for this system. And also from the perspective of financial resources, if we go for the Nyss system, and if we again opt for locally in-country in-build system of the Nyss, So there might be the need of additional resources. So basically my question is, because Nepal, it itself is a low income country, so how other countries which economic status is similar to Nepal, but they are utilizing Nyss system, so how they are coping with the resources and all?
Yeah, I think this is a great question, and also I encourage you to continue to look during this. I do continue to advise you to keep kind of thinking through this at all the different pieces of the CBS assessment, because not only it is a little, we do advise trying to keep it as financially sustainable as possible. Even in higher income countries, it's not sustainable if something is cost prohibited. So with Nyss and the data source, I do want to emphasize, with the data there now, the countries who are using it are using the cloud-based solution. And so this is one of the benefits to this, though, is that it also allows the system to continue to be updated and integrated kind of with this global solution structure. And I'm bringing that up because in past projects I've worked on where it comes with this kind of push and pull on technology and storing data, that the cloud-based systems tend to, in the long term, function a little bit better because you are able to continue to do these updates and it's interlinked. However, the data itself is always owned by the National Society and following all of the data protection principles as well. So at this time, those who are using the Nyss system specifically, they are using that cloud-based solution, which does free up a little bit more in terms of this financial capacity to host is a little bit more restrictive. You probably, if I understood it correct yesterday, is it Nepal that has this the policy that all data must be held on an in-country server, if I understood it? Is that correct? Okay, thank you. So Nepal, it won't be the only country where we've had this. And I think it's important, one, to continue to discuss how no personal identifying information is stored. In this, the only personal identifying information that is stored is that link to volunteers, which would only be visible to the National Society, which generally the National Society already has this information anyways on volunteers, but not within the additional community. I just think that wasn't really highlighted yesterday. But when it comes to the server, I would say this is probably the biggest piece. However, once it's set up, so the initial costs of setting it up in an external location, so within Nepal, for example, once that initial cost is done, the maintenance is the only piece that would have to be kept up. And so at this time, we don't have other countries doing that. I'm sure this will not be the only time we'll have to talk about it. I know Indonesia, for example, has the same policy in terms of storing data on the country and not cloud-based. And so there are ongoing discussions in several national societies on how to best approach it. It might be useful, though, for you to have a discussion as part of this assessment process to find out how cost prohibitory it would be to set up an external database within Nepal, and talk to some kind of technical and IT professionals in country to see if you can get a better understanding of the financial costs, because this this can vary quite a bit country to country, and I wouldn't want to say it's necessarily too expensive in Nepal, because it may not be. And through kind of linking this project also with other partners, I think it's also important to keep that in mind as well. And if you're linked with Ministry of Health and WHO, to kind of, if the cost seems reasonable and then it matches all of the requirements by the by the government on data security, then I think it's definitely something to include in your assessment, and then in those discussions with your partners. I'm not sure if that answers the question, but at this time, generally in terms of cost for the system, Nyss is quite, it's usually quite cost effective, but we are, most locations, as far as I know, all locations at this time are using the cloud-based server. But for example, I cannot access any of the data from any of the countries without them giving me permission. So it's definitely owned by the National Society. It's just stored in a remote location. And so that's how the cost kind of has been handled so far. Are there any, I'm conscious of time, and so I want to make sure, are there I'm sorry if I'm not helpful. I'm happy though, Rajan, to help strategize with you on this. I do appreciate a good brainstorm. So if you want to talk, if you get some quotes or some questions on this, happy to stay in the loop also with Norwegian Red Cross when looking at Nyss specifically, but happy to also brainstorm in general about cost strategies as well. So I just want to open up, if there's any other questions, to please let me know. I have been making notes of some additional resources to share with all of you in this kind of assessment process. And so I will follow up with those and some links as well. Is there anything else that I maybe skipped or missed today? No. Okay, I might try to wrap up then, but I also, just to remind everyone, I'm available and really happy to support however it might be useful for all of you based off of the needs. Happy to support remotely on any part of the assessment where it might be useful. And also, again, to brainstorm on different strategies or approaches, or if any other national societies have different examples. For the future, I will try to arrange a opportunity for national societies to share experiences with CBS. We're in the process of kind of gathering interest and exploring that option in the future as well. So, and just to have it open then for the national societies to share their own experiences with each other. I thought I saw a hand, but it's gone. Was there anything else? Yes.
Yeah. So yes, actually, it might be a very silly question, but just I would like to know about the community-based surveillance volunteers' role, especially to identify, recognize, and trace or verify the diseases. You know, like sometime in the communities, like the community might have multiple burden of diseases with similar signs and symptoms. So in that case, how the community based surveillance volunteers recognize, triage or verify the diseases and act accordingly?
Great question, and my answer is they shouldn't. That's not the goal, actually. And also a really good point, and I'm just adding this to my list of things to share. We do have a global list. By no means is it complete, I'm sure, but a global list of suggested health risks to look at. And you're right, community-based volunteers, we're trying to emphasize are looking at those signs and symptoms. And for those volunteers, the health action that's related to those signs and symptoms should be the same based off of that alone. And they don't need, unless they are also part of the case investigation team, which is possible. There are volunteers who work also in the health system. But unless they are already part of that system, it is not their role, and we don't want to put the burden of identifying disease specific on them. And that is the role for those who are engaged in the case investigation and also for the local health authorities. So, and those trained in health. The role for the volunteer itself is just to identify the health risk and to share kind of the key messages on how, for that community member, on how to take care of themselves or referrals, and then and that alert is sent up. And so that alert, usually we do recommend the alert sent up. That's recommended to be followed up within a 24-hour time frame. In which case, again, it's not on the volunteer to identify that, or to kind of say, okay, you have dengue, no, you have COVID, no, you have malaria. It's not their responsibility, and also it's beyond the capacity really of the majority of community volunteers to do that as well. But a really good question. But you also reminded me, I will share another piece on that as well, to also help during the process of thinking through which health risks you might want to consider. Okay. I think because of time, and I know everyone has been extremely busy, I'm just going to try to wrap up. But please do reach out again if there's any additional questions. I'll put my email in the message box again. And I'm happy to also support being kind of a link if I'm not the right person. And Abhishek also as a link to whoever can answer questions. But also I will be sharing kind of the additional resources discussed today, and trying to kind of give you some examples from other national societies on how they've approached some of these questions. But very excited to meet all of you, and very excited to continue working with all of you. Beautiful. I appreciate it. Thank you. And so with that, Abhishek, do you have any other remarks kind of from the regional perspective that you might want to include before we close?
No, means like one of the critical thing we have to understand with community-based surveillance, like as I think Bipul sir has also mentioned this, like COVID-19 can be the entry point, but this tool can really work and in other diseases as well. When there is a potential secondary health impact of COVID-19, we are seeing with potential rise of vaccine preventable disease and less health seeking behavior of people, as they are very afraid to go to the health facilities. So this can be a very, very good tool. One of the challenges most of the country do face in community-based surveillance is harmonization with the national system, like how like as Rachel has also mentioned, like how we don't overburden the health information system, and also harmonize our tools and system that can easily feed into the national health information system. That is something I think if Red Cross and the WHO can work out, and then we can also adapt our tools accordingly to fit the Nepal health information system through the CBS, and having that role of a supervisor is quite crucial in just filtering out the thing. And there should be very clarity that we are not diagnosing the disease. We are just trying to identify the symptoms or the particular type of group of symptoms that might point to several disease. Then once it is reported, it is the Ministry of Health or someone who comes and investigate and try to find, okay, this is it. Like even the COVID symptom can be for many things. So that is what is very, very important. And getting digitalization, community-based surveillance is something that is really supported by the Secretary Generals and ministry and all the senior management of different national societies in the Manila Call for Action. And this can be a good move around the COVID-19 to see all these in this. And there should be a good linkages with the digitalization of our work, and also how better we can support the Ministry of Health as an auxiliary to enrich their data. So the regional office is quite supportive around the community-based surveillance, also getting entry through COVID-19 and expanding it further. Of course, there are some roadblocks, challenges that will come through, but like once it is in flow, we have seen in different countries very excellent results around this. So it can be a very, very important tool that Nepal Red Cross might want to go ahead with it. Over to you, Rachel.
Okay. No, thank you. You brought up all of the extremely important key points here. So thank you again for everyone. And I'm sorry, I know we went much over our time. So thank you for all of those who joined, and really happy to keep these discussions going. And as mentioned, please do reach out for support during this process, because I agree with Abhishek full-heartedly that I think this is a very good opportunity, even given challenges, to consider kind of all of the options for community-based surveillance in Nepal. So please reach out, and I just want to say thank you to everyone. Once I receive the recording, I'll share that as well. All right.
Thank you, Rachel, and thank you
everyone.
team from Nepal. Have a nice weekend.
Yes, thank you, everyone.
Thank you.
Nice weekend to you
Okay,
too.
stay safe.
Thank you.
Bye-bye.
Take care. Take
Bye-bye.
some
Thank you,
rest for
Rachel, and
everyone.
thank you all. Thank you.
Great. Thank you.